welcome to the first class of the internal medicine series on cardiology. Today, we will focus on the anatomy and physiology of the heart. So the focus of today is to give you a basic but strong foundation of knowledge to build up for future classes planned in this series. By understanding the anatomy and physiology, it becomes easier to understand clinical diseases associated with cardiology. So let's dive straight in. If somebody asks you how to define the heart, you should be able to say that the heart is a hollow muscular organ located in the middle mediastinum. Its primary role is to pump blood throughout the body and deliver oxygen and nutrients to tissues and remove carbon dioxide. In terms of the shape, it is shaped like an inverted cone, and it's about the size of a fist. So about 12 centimeters long by 8 to 9 centimeters wide. And it weighs around 250 to 350 grams, varying with sets. And it functions to act as a double pump for the pulmonary circulation and the systemic circulation. So I like to think about the structure of the heart as the 4-4-3 formation. So adding a little football knowledge into this. So for any keen football fans out there, 4-4-3 is not a real formation, but it's a nice way to remember the very basic structure of the heart. Okay, so we have 4 chambers: right atria, right ventricle, left ventricle, 4 valves: tricuspid, pulmonary, bicuspid, and aortic, and 3 layers from out to in: the pericardium, myocardium, and endocardium. So if we just focus briefly on these diagrams, so the right side of the heart, so the right atria and right ventricle, deals with the deoxygenated blood, and the left side of the blood, so the left atria and left ventricle, deals with the oxygenated side of blood, of the heart, I mean. Now, in terms of the valves, I've put it there in that order for a reason. So this is the kind of this is the route that blood takes through tricuspid through the pulmonary valve. It goes into the pulmonary circulation, and then through and as it returns to the left atria, it goes through the bicuspid or mitral valve into the left ventricle, where that blood is ejected through the aortic valve into the aorta and to the systemic circulation. The layers of the heart we will talk about in a little bit. Now, in terms of the function, I think about the function in 2 ways: pumping function and the electrical function. So it's really important when you're faced with patients. So most patients don't really know how the heart works. So you have to make it really easy for them to understand what part of the function is actually going wrong. So with the pumping function, this is the mechanical function of the heart. So the heart is the central pump of the circulatory system. It is the engine. Okay, it is the one that facilitates the flow of blood all throughout the heart, all throughout the body, and the structure of the heart helps it to carry out this function. With the electrical side of the heart, we have rhythmic conduction of waves of depolarizations to help the heart contract and thereby eject blood. And clinically, when we speak about this clinically, these are the things that actually go wrong. So in terms of clinical context, I've only added one example because we'll talk about all of these. So in terms of the mechanical function of the heart or the pumping function of the heart, when we have valvular stenosis, in other words, the narrowing of the valves, we have the obstruction of forward flow of blood. So blood, it's much harder for the blood to go to its destination. So, for example, if we have aortic valve stenosis, it's much harder for the blood to go from the left ventricle into the aorta and to the rest of the systemic circulation. Now, why is that a problem? It is a problem because if you have less blood going to the tissues, we increase the risk of cardiac death and the risk of ischemic injury to organs. In other words, death of internal organs as well. So the volume of blood that reaches tissues is the medical word for it is perfusion. So if you reduce perfusion to the tissues, you increase the risk of death. Okay, so that's one example for the pumping function of the heart. With the electrical function of the heart, you may have heard of the word arrhythmia. Arrhythmia literally means impaired rhythm. Now, if you have an impaired rhythm of the heart, you have turbulent or unreliable ejection of blood. So sometimes you have the perfect amount of blood being ejected. Sometimes you have too little. But this is unreliable for the tissues. And therefore, we have reduced perfusion to tissues, and therefore we increase the risk of cardiac death and increase the risk of internal organ failure as well. Okay, so I hope that makes sense. So to recap that in particular, when you're with patients, when you're in front of patients and the patients ask you, oh, what's wrong with me? In a cardiac context, it's important to start and to describe the heart in terms of its pumping function and the electrical function. Okay. Now, in terms of the layers of the heart wall, so we have three layers. The three layers are endocardium, myocardium, and pericardium. Now, from in to out, so inside the heart to the outside of the heart. So inside the heart, we have endocardium, which is the inner lining of endothelial cells. And we have the myocardium, which is the thick cardiac muscles. And this is what contracts to pump blood, all right? And the pericardium is the fibrous serous sac that the heart sits inside. And this pericardium has fluid around it, pericardial fluid, and it allows for the expansion of the heart, and it allows for, and it has certain ligaments. So one example is sternopericardial ligament, so a ligament from the sternum to the pericardium, which allows the heart to stay in the middle mediastinum. Okay, so these are the three layers of the heart. Now, all three layers can have things go wrong with it. Okay, so an example, infective endocarditis. That is an issue with the endocardium, right? We have a little damage that is caused by jet lesions inside the endocardium, and that can get infected, right? Myocardium, you would have heard of myocardial infarctions, in other words, heart attacks. So myocardium is the muscular layer, right? The pericardium, so you may have heard of pericarditis. Um, so these what I'm trying to highlight is that these three things, there are things that go wrong with that, and we will expand upon all of this, but you need to have an understanding of what it is first. Okay. Now, I was drumming on about pulmonary and systemic circulation, but these are two very, very, very important things to understand when it comes to the heart. Okay. Now, let's first talk about the pulmonary circulation. So we have blood that enters the right the right atrium, and this blood then goes through the tricuspid valve into the right ventricle. The blood that enters the right atrium is nutrient-rich blood from especially inferior vena cava, which is obviously coming from the liver. Okay. Now, this nutrient-rich blood has red blood cells that aren't oxygenated, right? So this is venous blood. Now, this venous blood, this blood without oxygen, goes to the right ventricle, goes through the pulmonary valve, goes to the pulmonary trunk via the pulmonary artery. So, key thing, pulmonary artery, anything that goes away from the heart is called an artery. Anything that goes into the heart is called a vein, right? So this is quite important. Now, when this venous blood reaches the lungs, we have gaseous exchange that happens, right? We're not exchanging nutrients here. What we're exchanging is oxygen and carbon dioxide. This is super important. So that's the only thing we're bothered about here. We're bothered about the movement of oxygen and carbon dioxide. So we're exhaling carbon dioxide, and we are moving oxygen molecules into the red blood cell. So we do that through alveoli and very short diffusion distances. So when we oxygenate that blood, right, that blood is brought back to the heart, to the left side of the heart, to the left atria, via the 4 pulmonary veins. Now, this, once it reaches the left atrium will pass that blood in through the mitral valve into the left ventricle. And the left ventricle will then pass that blood through the aortic valve into the aorta, where it enters the systemic circulation. So the systemic circulation will have oxygenated blood, oxygenated, nutrient-rich blood that then that also may contain some waste products that will then be later hemofiltered or filtered out in the kidney. Right. So all of these things are connected to each other. This is why I'm mentioning the liver and the kidney within my explanation. But eventually it will go and perfuse into all of these tissues for our vital organs, and this circle or this loop will continue. All right. So this is the importance of the pulmonary and systemic circulation. And the main driving factor, or the main engine, is the heart. The heart is the one that facilitates all of this. Now, let's talk about the cells of the heart, right? Before we go and look into all the chambers and stuff, let's talk about the cells of the heart. So in terms of the cells of the heart, an understanding of the cellular structure of the heart makes it very easy to understand, okay? In my opinion. Now, primarily, the heart is made up of contractile cells called cardiomyocytes. They are found in the myocardium of the heart, right? And what they do is that they generate the force for systole and diastole. Systole is the contraction of the heart. Diastole is the process where we have the filling of the heart, okay? Now, clinically, how is this relevant? When you have a damage to the myocardium, in other words, myocardial infarction, we impair the ability of the heart to contract, and therefore we go into something called heart failure. Heart failure is a situation where we're not able to pump enough blood around the body to maintain our metabolic or oxygen demand. So tissues have oxygen demand. If we're not able to maintain that, this is a situation called heart failure. We then also have to think about pacemaker cells. Now, pacemaker cells, the posh word here is autorhythmic cells. I never use the posh word, but pacemaker cells are they're self-driven. Okay, they will generate and conduct electrical impulses by themselves, and the ability of this cell to do this is called automaticity. Okay. Now, where is it? Well, it's all over the conduction system of the heart, which we'll talk about, but it's in the SA node, AV node, bundle of His, Purkinje fibers. But these pacemaker cells are found everywhere, okay? They're quite sensitive, right? And that is their function, to conduct electricity, and in the case of the SA node, to generate electrical impulses. Clinically speaking, the abnormal firing of these pacemaker cells is what causes arrhythmias. Now, scary arrhythmias like VT or AF, heart blocks, they're all to do with how the pacemaker cells function. So if you remember from what I said earlier, this is what really so these pacemaker cells are what really hinges on the electrical function of the heart. This is what's important for the electrical function of the heart. Okay. Now, just like most other organs, we have endothelial cells. This is what lines the endocardium of the heart, and the coronary vessels. Coronary vessels, blood vessels that supply the heart muscle. Okay. Now, the function of the endothelial cells is to provide a smooth lining, and it regulates vascular tone via nitric oxide and endothelin. So especially when we have sympathetic, so flight or fight responses, or parasympathetic rest and digest responses, these endothelial cells regulate vascular tone. It does so with vascular smooth muscle cells as well, which we'll talk about in a moment. But a smooth lining is super duper important because we want laminar flow of blood, okay, or smooth flow of blood. Now, why do we want that? All blood vessels have pressure inside it, so we call that intravascular pressure. So if it's inside the inside arteries, we have the intraatrial pressure. We also have inside the veins, we have the intravenous pressure. So these two things are super duper important to define how well we can perfuse our tissues. Okay. Now, if a dysfunction of this can be caused by things like atherosclerosis. So atherosclerosis is a situation where we have a cut in the endothelial layer of a blood vessel, or the heart, doesn't actually matter, and you have the deposit of dead cells, debris, and this can, and fat cells, and this can calcify and reduce the lumen, in other words, the size of the blood vessel, and therefore what that can do is cause ischemia, because it takes more pressure for blood to pass through. It prevents the laminar flow of blood, right? And due to Virchow's triad, we can increase the chance of the blood coagulating and therefore cause thrombosis. A thrombotic injury can cause, for example, damage in the myocardium, therefore cause myocardial infarction. Okay. Now, the next one is fibroblasts. Fibroblasts are kind of connective tissue. Okay, they produce the structural support of the heart through collagen, the production of your collagen and elastin, things like that. And the importance here is actually to do with genetic kind of problems of the heart, which we'll again talk about later. But things like cardiomyopathy, so certain types of cardiomyopathy will have loads and loads of fibroblastic activity that causes the heart to become very rigid, and it doesn't dilate properly, and therefore the heart can't function properly. Okay, and fibrosis is seen in when you after somebody has a heart attack, because that dead tissue is then layered with new tissue, and this new tissue is not as good as what we actually developed when we were born, okay, or when we were before the before MI. So you may have read up already about scar tissue, things like that. That's actually caused by these fibroblasts. Okay. Then we have vascular smooth muscle cells. So these vascular smooth muscle cells are found in the walls of the coronary arteries and arterioles, and they control coronary blood flow by contraction and relaxation. And the reason why I put this one in there is because these can cause these can vasospasm. So these can become spasmodic, and it can cause something called Prinzmetal angina, or coronary vasospasm. Angina, posh word for pain. Angina pectoris, posh word for chest pain. The main cell that is affected by coronary vasospasm is vascular smooth muscle cells, because they're the ones that control coronary blood flow by contraction and relaxation. When they go a bit mental, that's when we have the spasm of the blood vessel, and therefore we have chest pain. Now, this is a type of angina. So we have other types of angina: stable angina, unstable angina. These are a little different, but Prinzmetal angina is by and large, by and large, it's not fatal. It's not something that where we need to do too much about immediately, but it can happen in some people because of the dysregulation of vascular smooth muscle cells. Now, finally, immune cells. So immune cells, there are immune cells within the myocardium, and they wake up after injury. Okay, so especially for so what they function, what their function is all to do with the regulation of the kind of the heart muscle. So if it gets infected, these immune cells are recruited, and we, in terms of clinically speaking, these are mainly seen in things like myocarditis, post-MI inflammation, and chronic remodeling. So I know that was quite long-winded, but this bit, if you understand the cells that make up the heart, you will understand the clinical relevance of the clinical conditions within cardiology pretty easily. So give this a good read. Try to understand it the best you can, and hopefully it will all make sense as we go along through our series. Now, let's talk about the chambers of the heart. So first, let's look at the right atrium. Now, in terms of the right atrium has a couple of parts that we need to know, all right? We have the smooth part, which is also known as the sinus venarum. We have the rough anterior part called the pectinate part, and we also have the interatrial septum, which separates the two atria from each other. The smooth part, or sinus venarum, receives venous blood from various tributaries and inlets. So we will talk about that in a bit, but essentially this is where venous blood will come into the right atrium. Okay, the pectinate part is the rough part, and this includes the right auricle and contains pectinate muscles, which are important for the function of valves. Now, why is it rough? It's rough because it increases the pressure, the intra-atrial pressure, by making blood turbulent. Right, so this allows the valve, the tricuspid valve, to open. This is separated from the smooth part by crista terminalis and sulcus terminalis. Now, I don't really mind if you remember these two things, as long as you remember that there are these three parts. That is enough. Okay, but the smooth part is separated from the rough part by the crista terminalis and the sulcus terminalis. All right. And as I said, the intraatrial septum is where is what separates the right atrium from the left atrium. And one of the key kind of anatomical features that we see here is fossa ovalis. So during fetal life or fetal circulation, we have foramen ovale. So foramen ovale, you have maternal blood that kind of mixes with the left side. So the maternal blood is oxygenated already. So this comes to the right atrium and then passes through into the left side through the foramen ovale. Ignore the comment that is made over there that causes deoxygenated blood to pass into the left atrium. That's not true. So foramen ovale can, so when you're born, some babies might have foramen ovale. This is a congenital defect in a child, and there are many different kind of congenital defects you can have in a child, but this is one of those that you need to close. So when it's closed, it is seen as the fossa ovalis. So fossa is kind of like a depression, little dip. Okay, right. Now, right atrium. So I spoke about tributaries and inlets. Now, what does that mean? So I use the word inlet. mainly. The inlet is essentially the veins that open up into the right atrium. So the right atrium, as I said already, the right side of the heart deals with deoxygenated blood. The right atrium receives deoxygenated blood from the superior vena cava. So the superior vena cava is generally bringing blood from the head, neck, and upper limbs back into the heart, and it opens up at the upper part of the sinus venarum, the smooth part. Okay. The inferior vena cava opens up at the lower sinus venarum, and it is guarded by a rudimentary eustachian valve called the valve of inferior vena cava. Now, so the inferior vena cava deals with blood that's coming up from the lower limbs, the internal organs, and the blood inside this is nutrient rich. If you remember, this is quite important for what I mentioned about the pulmonary and systemic circulation, but this is nutrient rich blood, right? Now, why do we have a valve? The reason why we have valve is that we don't want the backflow of blood during systole back into the inferior vena cava, because the inferior vena cava has a certain amount of pressure inside it called the central venous pressure. Now, if you increase the central venous pressure, you can damage the right atrium, and you can also go on to cause backflow pressure or increase portal venous pressure. This pressure can cause hepatomegaly, and sometimes if it's really bad and over many years, it can cause it can also cause splenomegaly. Okay, so this is why we have valves. This particular valve I included for this reason, so I can explain this reason. But the other valves are not, it is not that important, but it's still nice to know. Okay. So the next is coronary sinus. So the coronary sinus opens between the inferior vena cava and the right atrioventricular orifice. So this is guarded by a valve as well called Debesian valve, or Debesian. I call it Debesian, right? Can't pronounce things, but it's called the Debesian valve. So again, to prevent backflow of blood, right? Because the coronary sinus is dealing with blood that is draining from the coronary veins, all coronary veins except from the anterior cardiac vein. Now, a backflow of blood into the coronary venous circuit can cause increase in the intravenous pressure, and it can actually cause fluid to seep out into the pericardial sac through the fenestrations of the venules, and therefore it could cause things like pericardial effusion, and much worse, tamponade, which could lead the heart to arrest because it can't dilate properly in diastole. But again, we'll talk about that later in the series. And we have the anterior cardiac vein, which opens directly into the anterior wall of the right atrium. Not much to talk about there. And we have the venae cordis minimae. So these are Debesian veins. They're numerous small veins opening from all four chambers of the heart through small foramina. Okay, these are mainly draining blood from chorda tendineae, the pectinate muscles, things like that, really. So these are very small blood veins, and it's coming from all corners of the all four chambers. Right. Now, outlets. So what's coming out of the right atrium? Now, blood is, so this venous blood that we've collected from the inlet is led into the right ventricle, and it is done so through the right atrioventricular orifice. And this is guarded by the tricuspid valve. What the valve does is that it ensures the unidirectional flow of blood from the atrium to the ventricle during ventricular diastole. Diastole means filling, or ventricular filling. The pectinate part of the internal anatomy, which I mentioned a bit earlier, ensures enough pressure is built up by the turbulence of blood to open the valve. So this pectinate part, or the rough part, is important in building up intra-atrial pressure enough that it can open the tricuspid valve and allow the blood to flow from the right atrium to the right ventricle, okay, through the tricuspid valve. Now, let's talk about the left atrium. So, left side of the heart deals with the oxygenated blood. So, the left atrium has receives oxygenated blood from 4 pulmonary veins. Right. These are the only veins that carry oxygenated blood. Right. So anything that goes into the heart is a vein. Anything that comes out of a heart is an artery. So usually these so we have 2 pulmonary veins that from each side of the lung. So we have so from the superior side of the lung and the inferior side of the lung. But the key thing is we have 4 pulmonary veins, right? Now, in terms of an outlet, that this blood that collects up in the left atrium flows through the left atrioventricular orifice into the left ventricle. Now, this left atrioventricular orifice is guarded by the mitral valve. And this valve, just like all the other valves that we've spoken about so far, ensures unidirectional flow from the atrium to the ventricle. And then during ventricular diastole, in other words, filling of the heart. All right. Now, the left atrium has internal surfaces as well. It's nearly the same as the right atria. So it has a smooth-walled main cavity. It's just not called sinus venarum, okay? But it's a smooth part. So this is where we receive the openings of the 4 pulmonary veins. Then we have the rough anterior part, and this rough anterior part is what we call the auricle. So this contains pectinate muscles, which again increase left intra-atrial pressure, and thereby opening up the mitral valve to allow the flow of blood into the left ventricle. And then we have the interatrial septum. Now, this interatrial septum also has the fossa ovalis, which is the only reason why I talked about it, right? So this is where the foramen ovale will be visible in the fetal heart. All right. A sec. Right. So we have the right ventricle. The right ventricle is a triangular chamber, and this receives blood, deoxygenated blood, from the right atrium, and then it pumps it to the lungs through the pulmonary trunk for oxygenation. So let's talk about the external features of the right ventricle. So it has 2 surfaces. It has an anterior surface, which is also known as the sternocostal surface. So that's the side that faces the sternum and the ribs. And we have the inferior surface, which is the diaphragmatic surface. So that faces the diaphragm. Okay. And in terms of internal features, we have 2 orifices. We have the right atrioventricular orifice, in other words, the tricuspid orifice, guarded by the tricuspid valve, and we have the pulmonary orifice, which is guarded by the pulmonary valve. So this valve is what guards deoxygenated blood in the right ventricle to go into the pulmonary trunk or the pulmonary artery into the lungs to get oxygenated. And we also have the left ventricle, the big daddy. Now, the left ventricle receives oxygenated blood from the left atria and distributes it through the aorta into the systemic circulation. So the circulation of all of the other vital organs and peripheral tissues, etc. Okay. Now, the key thing here is that the left ventricle is 3 times the size of the right ventricle. Okay, so it's got a very dense volume of myocardium around that area. In terms of internal features, we have a lower rough part called the trabeculate carne. So carne literally means meat, and upper smooth part called the aortic vestibule. We have two orifices here. So the left atrioventricular orifice guarded by the mitral valve or the bicuspid valve, and we have the aortic orifice, which is guarded by the aortic valve. In terms of external features, we have some sides that we need to know. Okay, so we have the anterior or sternocostal surface, the inferior or diaphragmatic surface. Now, have this noted in your head. This becomes very important when we're reading ECGs. Okay, the anterior side of the heart, inferior side of the heart. We're essentially picking up these electrical signals that we see on the ECG in very, very acute presentations, like for example, anterior MIs or inferior MIs from the electrical activity that we can detect from these kind of surfaces of the heart. Okay, and we have the left side of the heart as well. So anterior, inferior, left. So the anterior surface is facing the sternocostal surface, so it's facing the sternum and the ribs, and the inferior surface is facing the diaphragm. Okay. There are two very well developed papillary muscles, anterior and posterior, and we have something called chordae tendineae. So chordae tendineae is the romantic guy, the heartstrings, and they attach the free edges of the valve leaflets to papillary muscles within the ventricles. Now, what the hell are papillary muscles? So papillary muscles are muscles that project, they're muscle projections that apply tension to the chordae tendineae, and it allows it to recoil. So it allows the valve to recoil or snap back into place during systole. This tension that papillary muscles apply to the chordae tendineae is what allows a very tight seal so that we don't have the backflow of oxygenated blood from the left ventricle to the left atrium. And remember, I had to write that as a reminder as well. The left ventricle is 3 times the size of the right ventricle. All right. Now, I also want to have a chat about the cardiac skeleton. So the cardiac skeleton is something that is typically overlooked when we study the anatomy of the heart. And I don't think enough importance is given to this when we are, during second year, when you're doing anatomy. So the cardiac skeleton is known as the fibrous skeleton of the heart, and it is a structure of connective tissue that forms and anchors valves and influences the forces exerted by and through them. So clinically, this is really relevant for arrhythmias, valve diseases, age-related calcifications, surgical repairs. So let me have a little chat about them just to make it a bit clearer. So the cardiac skeleton has 2 main functions. It has a mechanical function and an electrical function. The mechanical function is that it has valves and muscles. It holds the valves and muscles in place and prevents the overdilation of the heart. And it does so through dense fibrous connective tissue rings called the annuli. These annuli are kind of all around these valves. I don't know if you can see my cursor, but essentially the red bit around the mitral valve, the blue bit around the tricuspid valve, these are all this is what the annuli kind of look like. Okay, it's like a fibrous ring. Now, what these rings do is that they anchor the valve leaflets in place. It provides an attachment site for all of all of the atrial and ventricular myocardiums. Okay, and very, very importantly, it stops or resists the overdilation of the heart, because a disorder of this is what causes regurgitation. So we can have mitral regurgitation, tricuspid regurgitation. It's because of a disorder. It can be because of a disorder of the cardiac skeleton, right? Um, Now, so that's the first function. So that's a mechanical function. The second function is the electrical side, electrical function that this holds. So the fibroskeleton is a non-conductive kind of structure, and it acts as an insulating barrier. So this is really important because you have lots of electricity that's passing through the heart. Okay, and what stops the heart from getting electrocuted? It's actually the cardiac skeleton. So number one, it prevents random impulses from spreading to the atria and the ventricle. Now, I'm going to repeat that because it's so important you understand this. It prevents random impulses from spreading from the atria to the ventricle. Okay, so keep that in mind. So number two, it forces electrical activity to funnel through the AV node and the bundle of His to its correct destination. Okay, and three, it ensures the delay that is typically associated with the AV node, which allows for ventricular diastole. In other words, ventricular filling, right? So, so for the third time, I repeat, prevents random impulses from spreading from atria to ventricle. So this is clinically important because you may have heard of accessory pathways. So things like Wolff-Parkinson-White syndrome, arrhythmias, AF. These things are actually fundamentally underpinned by a disorder in the cardiac skeleton, right? So accessory pathways that bypass the skeleton can cause short circuiting. So these accessory pathways bypass the cardiac skeleton and causes havoc on atrial and ventricular contraction, right? And what did I say a disorder in the electrical function of the heart cause? It reduces perfusion to the tissues and thereby may cause cardiac death and therefore may cause internal organ death and therefore cause death, right? This is why I'm really focusing on that, okay? And you may have heard of kind of calcifications of the valve of all of this. So the calcification actually happens on the skeleton of the heart. So for example, aortic stenosis, one of the key risk factors is calcification of the valve, and the calcification is actually of the skeleton that overlies the aortic valve. So this causes this can cause things like impaired AV node conduction, and if there's impairment of conduction of a wave of depolarization, especially in the AV node, we can have conduction disorders like heart block. Okay. Now, finally, for the surgeons among you, cardiothoracics hinges, so cardiac surgery hinges on the understanding of what the cardiac skeleton is. So surgeons actually use cardiac skeleton when they sew mechanical valves in, especially mitral valves. So having an understanding that there is a cardiac skeleton and this is how this cardiac skeleton works will make it very will make future classes, future kind of lessons on heart diseases a bit easier to understand. Okay, so I hope that makes sense. Now, the conduction system of the heart. The conduction system of the heart is just a specialized network of excitable cells. This is the electrical side of the heart, the electrical function of the heart. And what we're doing is generating and transmitting electrical impulses, and we're ensuring coordinated contraction of the atria and ventricles. That famous, that beautiful sound, lub dub. Okay, that's what we're trying to do. Now we have some components. So the sinoatrial node, AV node, the bundle of His, right and left bundle branches, and the Purkinje fibers. So this slide shows, if you look at the picture here, this shows basically an outline of the heart, okay? And this is the conduction system of the heart, right? Now, the sinoatrial node contains pacemaker cells, which we talked about earlier, that instigates the wave of depolarization. This wave of depolarization will depolarize or excite or cause atrial wall contraction. And if you look, again, I don't know if you can see my cursor, but if you look at the internodal pathways, this impulse starts at the sinus node, and then it gets passed down the internodal pathways into its destination, which is the AV node, right? This is a junction, right? AV node is a junction. Now, at this junction, at the AV node junction, what we have is that we have a very clinically important thing occur. We have the delay of the transmission of wave of depolarization. This delay is crucial to allow the ventricle to fill properly in a process called diastole. Okay, it is crucial. So this this delay at the AV node junction is crucial for the filling of the ventricles during diastole. This wave of depolarization is then passed down the bundle of His. So this is through the interventricular septum. So the interventricular septum separating right and left ventricles, and the bundle of His will then pass it down to the right and left bundle branches. Okay, and this separates the wave of depolarizations by intensity. So the stronger the intensity of the waves, the more likely it's going to go to the left bundle branch. So you kind of concentrate more of the electrical impulses on the left side to the left bundle branch, because what you want is the stronger contraction of the left ventricle, because it's 3 times the size of the right ventricle. Now, so it facilitates this through the Purkinje fibers. So the Purkinje fibers is quite deep inside the myocardium, and these fibers are what actually gives the kind of stimulus to contract with force these ventricles. All right, so so especially with right and left bundle branches, these can get blocked. And in an ECG, this is pretty, pretty damning results for a impending cardiac event. In other words, an MI. So if we have the block of the left bundle branch, for example, and we recognize it from the ECG, we need to be a little bit worried, because if we have a left bundle branch block, we may not be able to get enough blood ejected from the left ventricle to the systemic circulation, and we may have an impending cardiac event, with, in other words, perhaps an MI. Okay, so this is some clinical context to this. So I hope that makes sense. Now, very briefly about valves. Now, I know I've already talked about valves earlier on in this lesson, but I just wanted to just show you this picture and just tell you that what valves are for the unidirectional flow of blood. Valves prevent the backflow of blood, right? And they are essential for the efficient working of the heart, and also the efficient working of our blood vessels as well. Okay, we will talk about valvular disorders in another class, but the 4 valves that you need to know are the tricuspid valves, the pulmonary valves, the mitral bicuspid valves, and the aortic valves. Okay, now the heart is a very tasteful organ, right? It likes its Mercedes Benzes. So if you look at the tricuspid valve, the aortic valve, the pulmonary valve, all of them, they got their Mercedeses. The bicuspid valve is a bit questionable. That's because it's bicuspid. right? So it's just got it's just got two leaflets. So these are these have three leaflets or three cusps. So the aortic valve, tricuspid valve, and the pulmonary valve. So they just think about the Mercedes-Benz, right? The heart's a tasteful organ. Think about the Mercedes-Benzes. There are three Mercedes-Benzes: tricuspid, aortic, pulmonary valves, right? Okay. Now, yes. So, and in terms of the structure of the valves, so valves are lined with endocardium. Now, this becomes important a bit later, but when you have things like infective endocarditis, valves can also get affected, and this can therefore affect the function of the heart. Heart valves are, as I said earlier, situated around the fibrous rings of the cardiac skeleton, and each valve consists of thin, strong flaps of tissues called leaflets or cusps that open and close like doors. So these are leaflets or cusps. Again, I'm hoping that you can see my cursor, but see the Mercedes-Benz, there we go. These are all leaflets and cusps, all cusps. You can call it either, don't really mind. Now, I mentioned this a bit earlier, but we have chorda tendineae for atrioventricular valves. So, as I said, the romantic one, the heartstrings, that's chorda tendineae, right? So they attach to the free edges. So this bit here, this bit here, this bit here. So they attach to the free edges of these valve leaflets. And we also have papillary muscles that are within ventricles. So that's that kind of like on the underside of the valve on the ventricular part. So this is what these are, kind of muscle projections which apply tension to the heartstrings and allows it to recoil or snap back into place during systole. And this tension allows a tight seal and prevents regurgitation of blood into the atria from the ventricle. Okay. Now, let's talk a bit briefly about the blood supply of the heart. Okay, so before I go on to the next slide, I want to be very clear about something. So that the heart is involved with the pulmonary and systemic circulation. That's its job, right? But the heart also needs food and oxygen, right? And that's what we're looking at here. And that is facilitated through the coronary vasculature. And firstly, we have the arterial supply that we need to know. So we have two main coronary arteries that supply the entire heart. We have the left coronary artery and the right coronary artery. Now, the left coronary artery branches to form the left anterior descending artery. So that's the LAD artery. Now, sometimes in some textbooks, if you're a bit of a connoisseur, you will also hear it being mentioned as anterior interventricular artery. But in my clinical career, I've never heard of that. But I thought I'll just mention that anyway. But left anterior descending, the LAD, the LAD. This is super important because it supplies the left ventricle. Now, in the right coronary artery, it branches to form the right marginal artery anteriorly. So this is supplying the right ventricle, the right side of the heart. Okay, so these are the two arteries I want you to know because they have clinical contexts, clinical significance, I mean, a bit later on. And in terms of venous supply, the heart also needs the drainage of deoxygenated blood and waste products. So from the subendocardium, we have blood that drains into the Thebsian veins. So these are those small veins that I mentioned. So that's through there, and it drains into the larger larger veins that empty into the coronary sinus. So this coronary sinus will drain into the right atrium. So this very nice little picture shows which are those veins. So the great cardiac vein, small cardiac vein, middle cardiac vein, left marginal vein, posterior ventricular vein. And for the keen viewers, you may have noticed that there's one more artery that we missed out, and that is called the anterior cardiac vein. Okay, so that's also another vein that drains the cardiac wall, or the myocardium. Right. Right. So I hope you like my class. I really appreciate some feedback. So these classes are for your benefit. So I really appreciate some constructive feedback, and I hope to deliver some more useful classes for you. So thank you very much.